Assalamualaikum warahmatullahi wabarakatuh. I'm Dr. Wan Faiziah Wan Abdul Rahman from University Science Malaysia. This is a recorded slide teaching on endocrine pathology practical for my Master of Pathology Phase 1 students and also useful for undergraduate medical students. As you all know, there are many endocrine organs in our body due to their potential to produce certain hormones. But what I want to focus today is only on pituitary, thyroid, and as well as on adrenals. Pituitary glands compose of diversity of cells that suits with their function in producing variety of hormones. As you can see here, some of the cells contain eosinophilic granular cytoplasm that we call it acidophils, and some of the cells with a basophilic cytoplasm, and the cells which we call it basophils, and the cells in between we call it chromophobe cells. These cells intermingle each other in checkerboard-like appearance and arrange in acini pattern. Acini means a small cluster of cells or a sac-like cavity in a gland. How to differentiate whether the cells are normal pituitary or adenoma or hyperplasia? One of the most reliable methods is the lack of reticulin network within the tumor. The normal pituitary, this reticulin stain is supposed to stain the reticulin fibers surrounding the small acini of the pituitary cells. When there is a large cluster of cells without reticulin like this, definitely it is adenoma. This features indicating of reticulin breakdown. In hyperplasia, the expansion of reticulin boundary is less and less dramatic as compared to adenoma. The second method is by recognize the morphological features. First of all, in adenoma, it has a well circumscribed tumor with monotonous population. This monotonous population is because the monomorphic expansion of one cell type only. For example, in this case, the cells predominantly basophils. They can arrange in few growth patterns like in sheaths, trabeculae, pseudoacina, or pseudopapillary. As you can see here, the cells arrange in sheaths and some in pseudopapillary formation. About 75% of patients present with signs and symptoms that related to mass effect, for example, headache, blurring of vision, and the rest presented with hormone excess symptoms such as galacturia or acromegaly. This case is from 45 female with blurring of vision and headache, and sometimes they may give you history of sellar tumor. So from the history, almost 50% you can guess the diagnosis, and you have to describe what displays here. So what obvious here is the monotonous population of the cells. The cells exhibiting round to oval uniform nuclei with eosinophilic granular cytoplasm or acidophils, and the cells arranged in trabeculae formation or papillary-like formation. Under higher magnification, we can see the monomorphic appearance of tumor cells with round to oval shaped nuclei, stipple chromatin or salt or pepper chromatin patterns within the nucleus, and the cytoplasm here is abundant, containing eosinophilic granules, and the tumor cells arranged in acina-like pattern with lumen space in central. So these are all the features of pituitary adenoma. Let's move on to the next organ, which is adrenal glands. This is a typical gross image for adrenal cortical adenoma. As you can see here, this is a very nice layers of cortex and medulla, the outer cortex and inner medulla of normal adrenal gland. And at one end, there is a solitary, well circumscribed nodule arising from the cortex. You can see this is a yellowish color and forming a yellowish nodule. This image also similar, where you can see there's a very well circumscribed tumor nodule arising from the cortex of adrenal gland, and the cut surface of the tumor is solid yellowish, no hemorrhage or necrosis, and there is a normal adrenal gland areas showing layers of outer cortex and as well as the inner medulla. For histology, we then take a section from the normal adrenal gland as well as within the nodule together with their capsules. Section from the adrenal gland, section from normal adrenal gland shows the outer cortex and inner medulla. And then just beneath the capsule, there is a thin zona glomerulosa just beneath the capsule, and at the mid portion of the cortex, which composed of zona fasciculata that comprises more than 50% of the thickness of the cortex. This is the thickest zona of the cortex, and this zone produces cortisol. The innermost portion is zona reticularis that producing the sex hormones. The layer just beneath the capsule is zona glomerulosa. We call it glomerulosa because it resembles the glomeruli. You can see here, it really resembles the glomeruli within the kidney. The cells in the zona fasciculata, which is the thickest layer of the cortex, is arranged in perpendicular to the capsules and back-to-back fascicles or plates that separated by blood vessels. And then the zona reticularis is identical to fasciculata, but the cells here arranged in meshward uniform cells. The section from the adrenal cortex nodule shows a well encapsulated tumor with layers of the normal cortex at the uppermost. The patient may just presented with incidental suprarenal mass or may be presented with hypercortisolism. Under higher magnification, it is a well encapsulated or well circumscribed tumor, and the tumor arranged in nests or cords or small clusters of uniform cells that been separated by a thin fibrous septa that containing the blood vessels. You can see within this thin fibrous septa, actually they have a thin blood vessels within. With the nuclei shows round small nuclei, and the cytoplasm is abundant clear to foamy cytoplasm with distinct cell borders, and there is no mitosis or hemorrhage seen. In another areas, it appears almost similar, but still it has uniform small round nuclei with packed small clusters or nest of cells with clear abundant cytoplasm. Okay, these are all the features of the adrenal cortical adenoma. Now we move on to the thyroid revision class. I will just emphasize on common exam cases. One of the example is Hashimoto thyroiditis. But for all thyroid cases, the history normally they will give you middle-aged women or sometimes any age with anterior neck swelling, or very rarely they give you hypo or hyperthyroidism, because we wanted you to appreciate the thyroid cells without giving you without telling you that the cells are from the thyroid. As you can see here, the cut surface of this thyroid is nodular with fleshy and whitish appearance that resemblance of the lymph nodes, and this is because this thyroid has been infiltrated by mononuclear cells in Hashimoto thyroiditis. The histology of the Hashimoto thyroiditis, you should at least search for few important features. For example, the formation of the lymphoid follicles with germinal centers. This is a lymphoid follicles with prominent germinal centers. The Hurter cell metaplasia, this is all the Hurter cell metaplasia. Diffuse infiltration of mononuclear cells within the lesion. There is a diffuse infiltration of the mononuclear cells. The atrophy of the thyroid follicles, and as well as increase in the interstitial connective tissue. Sometimes you cannot see all the features in one area, but you need to search for it. For example, in this case, in this focus, it only shows a dense lymphoplasmacity infiltrate with replacement of the normal architecture of the thyroid glands, and as well as damage of the thyroid follicular cells or thyroid follicle atrophy, and as well as increase in the fibrous tissue or collagenous tissue. In other areas, you may have these structures. Due to continuing inflammation, it causes metaplastic change of the thyroid follicular cells, and these cells we call it Hurter cells. These Hurter cells characterized by a large cells with fine granular eosinophilic cytoplasm and enlarged nuclei. sometimes the nuclei may show atypia, like this. But bear in mind, these cells do not produce any thyroid hormones. That's why, even though patient have many Hurter cells in Hashimoto thyroiditis, but still patient will present with hypothyroidism. So, as a conclusion, to diagnose Hashimoto thyroiditis or chronic lymphocytic thyroiditis, you should have all these features: the follicles, the atrophic follicles without colloid, diffuse infiltration of mononuclear cells, follicles that line by Hurter cells, or sometimes the Hurter cells may be in sheaths, and lymphoid follicles with germinal center. Right? Okay, next, the cut section of the thyroid gland shows a single solitary well-demarcated or well-encapsulated nodule. Okay, the cut surface resembles normal thyroid tissue with solid brownish and translucent, and the adjacent thyroid tissue is being compressed. So this is typical gross findings for the follicular adenoma. The section from the thyroid solitary nodule shows a well-demarcated or well-encapsulated tumor, and this tumor contains closely packed follicles, and the surrounding thyroid follicles, the thyroid follicle that's surrounding the nodule, can see here, is being compressed by the nodule. In another areas, under higher magnification, as you can see here, the tumor shows a well-demarcated nodule, and it composed of microfollicles without colloid or just implicated colloid in the middle, normal follicles, and as well as macrofollicles with abundant colloid. And the follicles surrounding the nodules is being compressed, and there is no capsular or vascular invasion. So, as a conclusion, whenever you have these structures, a well-demarcated or encapsulated tumor with a nice complete fibrous capsule and closely packed follicles lined by low cuboidal to columnar cells that surrounding by the thyroid tissue with compressed follicles, no capsular or vascular invasion. So this is follicular adenoma. The cut section from the thyroid shows a single, solitary, well-demarcated nodule, a solid to cystic mass with some hemorrhage inside, with a necrosis and as well as papillary projection. The section shows the thyroid cells that forming papillary structures. This is a papillary structures with a fibrovascular core at the central of the papillae, and apart from that, there are nuclear features like an oval shape of the nuclei and the nuclear grooving, the optically clear nucleus, and as well as intranuclear pseudo-inclusion. All of these are the nuclear features of the papillary thyroid carcinoma. And you can see under higher power magnification, you can see very nice intranuclear cytoplasmic inclusion, and as well as coffee bean shaped nuclei or nuclear grooving. Okay, and last but not least, you should find for the psammoma bodies. So as a conclusion, whenever you have a branching papillae with a fibrovascular core and together with the nuclear features that lining the papillae, and the nuclear features that exhibit clearing, inclusion, grooving, irregular membrane, oval, enlarged or overlapping nuclear features, together with the scattered psammoma bodies. This is a classical papillary thyroid carcinoma. Thank you. And if anything, you just email me at wfaizia@usm.my, and don't forget to subscribe to my channel. Okay, till we meet again. Okay, bye.